What's up, Ninja Nerds? In this video, we're going to be talking about pulmonary embolism. But before we get started, if you guys want to follow along with some really comprehensive notes, some great illustrations, drawings before the board's actually been filled out, drawings after, so that it can just help you to truly understand and kind of really follow along with this topic, please go down below in the description box. We have links to our website. You guys can get all of that stuff. Go check that out. Also, if you guys like this video, you benefit from it, it helps you, please hit that like button, comment down in the comment section, and please subscribe. All right, let's get into it. All right, Ninja Nerds, let's talk about pulmonary embolism. So, causes of pulmonary embolism. Before we start talking about that, what is a pulmonary embolus? It's a clot, a blood clot that develops within the pulmonary arterial circulation. Now, the question is, how did that clot actually develop? That's a great question, engineers. Let's talk about those. The most common cause, if you guys don't remember all of these other ones that I'm going to talk about, please remember this one. It's the most important one. The most common cause for someone developing a pulmonary embolus is they develop a clot, what's called a thrombus, that develops within a deep vein within usually a lower extremity most commonly. So what do we call that thrombus within a deep vein of the lower extremity? We call it a DVT. So usually a DVT, deep vein thrombosis, is going to be one of the most common causes of a pulmonary embolus. Now, how does that actually cause an embolus? There's a clot in the leg. How does it get to the lung? Generally, what happens is this clot is usually what's called a thrombus. So a thrombus is a blood clot that's kind of situated, it stays still in the vessel wall. But whenever that actual thrombus breaks off and gives a piece of the embolus, then now this embolus can freely circulate up through the IVC, into the right side of the heart, go flooding through the pulmonary arterial circulation. It can get stuck in a pulmonary artery. You got yourself a pulmonary embolus, okay? So big thing to remember, by far the most common cause of someone developing a pulmonary embolus is they have a DVT that broke off and then went through the pulmonary circulation. All right, what's another potential cause or etiology that I want you guys to think about for pulmonary embolism? Another one to potentially think about here is if someone is actually scuba diving, right? When they're scuba diving, they're usually under higher pressure as they go deeper and deeper and deeper. But whenever they rise back up quicker, sometimes what can happen is some of that nitrogen and oxygen, because of the pressure changes and the solubility changes within those gases, can form these air bubbles, okay? Whenever you rise too quickly, they call it the bends, and it can form emboli that develop within the pulmonary circulation, leading to a pulmonary embolus. And so another potential thing that you can think about here is what's called an air embolus. And the best classic case to think about this is when someone's they're scuba diving and then they rise too quickly, called the bends. Other potential causes is whenever somebody breaks a really big bone, usually a long bone. You know, within the long bones, they have a medullary cavity that's usually filled with fat. And so what happens is, if you get really good long bone fractures, so long bone fractures, within the center, the medullary cavity, you have all of this fat tissue. And so what happens is you can actually break off fat globules. And those fat globules have the ability to get stuck in some of the pulmonary circulation and cause a fat embolus. So that is another thing to potentially think about. So we got DVT being by far the most common, air embolus from scuba diving and quickly arising, the bends, very big long bone fractures where you open up that medullary cavity and some of the fat globules get out into the circulation, aggregate and cause a fat embolus. What else? Not as common, but something to think about whenever somebody they're pregnant. And what happens is whenever you're pregnant, you have this amniotic cavity, right? And sometimes in patients, maybe for some reason, maybe a premature birth, they have an opening, okay, of their amniotic fluid that leaks into the actual circulation. And some of the proteins within inside of the amniotic fluid are very immunogenic and can lead to clots, that actually little emboli that can form. And so sometimes you can get what's called an amniotic embolus. So that is another thing to potentially think about, especially in patients who are pregnant. Usually there's some type of premature complication associated with it. Okay? So we got DVT most common, air embolus, long bone fractures that cause fat emboli, and amniotic embolism that are usually during pregnancy. The other one is if someone is an IV drug abuser. Okay, an IV drug abuser And whenever they have this IV drug abuse, there's an easy way for them to carry bacteria, Staphylococcus aureus, different types of Staphylococcus species, straight from the skin into the actual blood. And then you know where those little nasty Staphylococcus species love to go, especially Staphylococcus aureus? It loves to go and kind of lay up its house on the tricuspid valve, okay? Especially in IV drug abuser, Staphylococcus aureus, it takes up residence on the actual tricuspid valve and leads to these really nasty vegetations. These little vegetations can then break off. And guess where they can go? Right into the right ventricle. From the right ventricle, they can go into the pulmonary circulation, and then they can get stuck or dislodged somewhere downstream within the pulmonary artery. And so these are called bacterial or septic emboli. So another one to potentially think about here is what's called bacterial or what's called septic emboli, okay, or embolus. Okay, so these are the big things that I want you guys to think about, okay, as potential causes of someone developing a pulmonary embolus. DVT most common, air embolus, long bone fractures causing a fat embolus, pregnancy, rupturing of the amniotic membrane leading to an amniotic embolus, or some type of IV drug abuser which has vegetations that form on the tricuspid valve, leading to infective endocarditis, vegetations that break off causing bacterial or septic emboli. Now, once all of these emboli floated through the pulmonary circulation, the problematic issue that arises here is that they get stuck in one of these pulmonary arteries or arterioles, depending upon how big the clot is, and that obstructs the blood flow distal to that occlusion. And in the lungs, what's this responsible for? Putting oxygen into the blood and getting rid of CO2. And so as a result, what we're going to see a little bit later here is that you significantly affect the gas exchange process, okay? And we'll talk about the negative ramifications of that, okay? So we have an idea of the basic causes, but what I really want us to focus on for the roast of this kind of like causes portion is DVT, since it is the most common, okay? So first thing that we need to know is DVT is a deep vein thrombosis. What are the deep veins that I should be aware of, that I should know? Because those are the ones that whenever I'm doing an ultrasound or I'm checking or I'm trying to look at the reports, I know which vessels are most commonly affected. Let's talk about that. So here we have this like nice little anatomical diagram here. Just to get the point across here, you have here your IVC, right? So this is your inferior vena cava. And then from the inferior vena cava, this branches off, right, into your iliacs. Okay, so let's say that this is the common iliac. And let's say off the common iliac is your internal iliac, so this is your external iliac, right? So this right here is your external iliac. Then coming down off the external iliac, you'll have the femoral. Generally we call it like the common femoral vein. And then off of that you have what's called a deep femoral vein that comes off of that common femoral vein. And then generally you'll have the continuation of the femoral vein, and that'll eventually go near the knee and produce what's called the popliteal vein. And then the popliteal vein will usually bifurcate and give way to what's called the anterior tibial vein. It'll give way to what's called the posterior tibial vein, and give way to what's called the peroneal or fibular vein. Okay, now these are deep veins. And so there's particular things, particular risk factors, particular causes that can increase the risk of clots that form within these vessels. So if you form a clot within any of these particular vessels, they have the possibility, the potential to break off, embolize up through one of these vessels upstream, go from the IVC right into the right atrium, right ventricle, pulmonary trunk, and then produce a pulmonary embolus. So the question is, what in the heck can lead to clots that form within either the external iliac, that form within the femoral, that form within the deep femoral, that form within the popliteal, that form within the anterior tibial, posterior tibial, or peroneal? Let's talk about that. So the first one that I want you guys to think about here, there's this guy, okay, he came up with a triad. You guys might see where I'm going here with this. He came up with this triad, and it's called Virchow's triad. Okay, and what he said is that there's three particular things that increase the risk of forming blood clots. Three particular things. The first one here is there is a increase stasis of blood flow. Okay, there's an increased stasis. Blood isn't really moving very quickly. It's staying within a particular area. And I found that whenever there's stasis of blood flow, there's an increased risk of blood clot. The second thing he said is, you know what I also noticed is that if somebody has what's called a hypercoagulable condition, meaning they have an increase in maybe like different types of procoagulant enzymes, so enzymes that want to induce clots, or they have a decrease in anticoagulant enzymes that are supposed to break down clots, there's less of them. And I know that whenever that happens, there's an increased risk of forming blood clots. And the last thing he said is, I noticed that whenever you damage or injure the endothelium, there's also an increased risk of forming blood clots. And the mechanism of this is actually relatively simple. You guys know our hemostasis video that we have within our hematology playlist. If you guys don't, you don't understand all of this stuff, we're not going to go into great detail. Go check out that video. It'll give you way more understanding about blood clots and how we form them. But generally, what happens is blood should kind of have a nice laminar flow through a blood vessel. Okay? If blood is kind of really stagnant in a particular area, you know what happens? Platelets love to stick to the actual endothelial vessels. And so what platelets will do is they'll come and stick to the endothelial vessels and start causing aggregation of other platelets. Okay? So whenever there's a stasis of blood flow, there's always going to be an increased opportunity for platelets to be able to stick to the actual blood vessels. If there's endothelial injury, platelets will come and stick to the blood vessels. And if you have tons of procoagulant enzymes or a decrease in anticoagulant enzymes, that's also going to increase the risk of blood clots. Okay? So we have the three aspects of Virchow's triad. We have an increased stasis of blood flow, hypercoagulability, or endothelial injury. Now, let's talk about each one of these particularly. The first one that I want to focus on as a potential cause is stasis of blood flow. Okay? So, with stasis of blood flow, what are potential things that you have to think about? What would cause someone to have a localized kind of slow flow through a particular venous structure here? The first one is like anything where the person is not utilizing. You know, there's what's called the muscular milking activity. I know it doesn't sound real, but there's what's called a muscular pump or a muscular milking activity. On the sides of your deep veins, you have muscles in your calves, right? And they're supposed to be, every time you're kind of contracting or walking around, you're utilizing those muscles. Maybe you're doing some calf raises, you're getting your gains, or maybe you're walking around and utilizing those muscles. Those muscles are squeezing and helping to push blood up through the venous structures. And so there really isn't much stasis of blood flow. But what if someone isn't ambulating? They aren't moving a lot. They're staying still for some reason, and they're not able to engage that muscular milking activity. What kind of conditions would do that? Maybe if someone is post-operative. So they're post-operative and they're on bed rest. Okay, so they're immobilized because they are post-op. And so they need to be on bed rest. Or maybe they're just immobilized for some other reason, okay? Maybe they just had like a fracture of their leg and they're stuck because they aren't able to move now because they have to rest their leg or they can't actually walk around on a cast or whatever it may be. Okay, so it could be post-op. You know, another potential thing is when somebody is had a stroke. So generally after a stroke, what happens? If you have a good enough stroke, what happens maybe to like one of the lower extremities? You can't utilize that muscle. If you can't utilize the muscles in this area, you aren't able to ambulate properly. And so sometimes paralysis after a stroke can also be a potential cause. So paralysis post-CVA, cerebrovascular accident, right? The next thing to think about here is airplanes. So long travel. So if someone's on an airplane for a long period of time, they're not moving. Okay, and so generally whenever there's like long airplane rides, usually greater than or equal to like 8 hours, there's not much movement within those lower extremities, and so there's an increased risk of stasis of blood flow and therefore blood clots. Same thing, not just airplanes, but also car rides, okay, where there's just these long car rides with not much time between to be able to ambulate, get some muscular milking activity going on. Okay, you guys will never forget that, the muscular milking activity. So we got stasis of blood flow, they're immobilized for some reason, post-operative, maybe they're paralysis after a stroke, they're kind of sitting in their car for long drives, or they're in an airplane for very long periods of time. What's another potential cause? Believe it or not, You know, you have these valves within our veins, okay? They're basically kind of like your endothelial lining. It's extensions of the endothelial lining. They form these things called venous valves. You know, in patients who develop what's called varicose veins, varicose veins is basically when they have these incompetent or leaky valves. Normally what valves do is, if blood would come from this segment, it would come up, and it's very slow. What would happen is we would want to prevent blood flow, because it's not under a lot of pressure, from backflowing, okay, into the segments just proximal. And so what happens is, let's say that it goes up, and then the pressure isn't enough, it starts going back down. We don't want it to go all the way back down. So what happens is we have these like little valves, these little venous valves, that basically kind of trap it and say, okay, blood's gonna stay here for now. But what happens if I have an incompetent valve? And so I push blood up here, and maybe the valve on this side helps to block it, but this valve's all jacked up. And because it's all jacked up, it allows the blood to kind of flow, again, proximal to that area there. And so blood can kind of stagnate. And if it stagnates, there's an increased risk of clots. So varicose veins is another potential thing, okay? The other thing that I want you guys to think about is, what if there's some type of compression of a vessel, and wherever there's compression, the stasis actually develops proximal to wherever that compression is. So blood's supposed to come here and then exit up here. But if there's something that's compressing it where very little blood is able to pass through, and stasis occurs at this area proximal to wherever that compression is, that could be a potential trigger. What are things that could compress on these actual deep veins? You know, someone's pregnant and their uterus is just smashing up against their iliac vein. That could be a potential reason. So it could be something like pregnancy. And pregnancy could have the uterus compressing up against the iliac vein. You know, there's another one. It's a very weird one, but it's an important one to remember for your exams. There's a condition called May-Thurner syndrome. May-Thurner syndrome. And in May-Thurner syndrome, what happens is you have what's called the right iliac artery, and then you have what's called the lumbar vertebrae. What happens is, between these two, the lumbar vertebrae and the right iliac artery, they squeeze and compress onto the iliac vein and decrease the actual blood flow up through the iliac vein. And that can again cause the increased risk of stasis of blood flow. And one more. What if you don't have a baby in there, you just got a little fat baby? Like, you know, I got a little bit of a fat baby. But obesity is another potential thing here that can cause compression of these actual deep veins because of the large amount of adipose, or, you know, kind of like centrally located kind of abdominal tissue that may be compressing on some of those actual venous structures. That could be another potential reason for stasis. So stasis, big things to think about post-op. When a person's immobilized, they're on bed rest, they got paralysis after a stroke, or they're, you know, sitting in a particular location without having the ability to ambulate for long periods of times, like airplanes and car rides. Varicose veins, or any compression of vessels like pregnancy, May-Thurner syndrome, and obesity. All right, let's talk about the second component of Virchow's triad. All right, so the second thing that Virchow said is, okay, let's think about things that can cause an increase in hypercoagulable states, where there's a problem with the coagulation system. There isn't an issue with like the stasis of blood flow. Blood is kind of flowing normally, but there's a problem where my coagulation system is either hyperactive, or I don't have enough enzymes to counteract that, the normal kind of like procoagulant function. So what am I talking about? Okay, generally, let's say here, we want to form a clot, right? Whenever you want to form a blood clot, you need very particular types of coagulant enzymes, procoagulant enzymes. So within our coagulation cascade, that would include things like thrombin, factor 12, factor 10, factor 5, factor 7. There's many different types of factors that generally want to cause a procoagulant type of activity, right? And you know, there's particular cases in which there is very, very specific cases. You know, there's a condition, it's one of the most common hypercoagulable conditions, called factor 5 Leiden. And what happens is there is an increase in procoagulant enzymes. Okay, I mentioned a bunch, but you know, not all of those do you actually see. So increase of procoagulant enzymes. Which ones would I want you guys to remember? The particular one is what's called factor 5 Leiden. In this condition, you have an increase in factor 5. Factor 5 is a procoagulant enzyme. If you have increased factor 5, you're going to want to be able to stimulate thrombus formation if you have a lot of it. Another one is what's called a prothrombin gene mutation. You know what this prothrombin enzyme does? Generally, prothrombin is a precursor for thrombin. So you have this mutation where you have an increase in the prothrombin actual like activator system and increasing prothrombin to thrombin. So you have an increase in thrombin. Thrombin is a very strong procoagulant enzyme. So you have an increase in thrombin indirectly, you're going to increase the formation of these blood clots. Okay? So an increase in factor V and factor V Leiden, or an increase in thrombin via the prothrombin gene mutation. What is other things? So these are the two big ones for increase in procoagulant. But what if there's actually, there's particular enzymes that want to break down the clots. They're supposed to be able to break down the clots. Protein C, protein S, antithrombin 3, beautiful enzymes that help us with this process. But what if we inhibit the anticoagulant enzymes? We decrease their ability to function, or we don't have enough of them. That would be a potential issue, right? So there's a decrease in anticoagulant enzymes. What are potential conditions that you want to think about here? These are usually something like what's called protein C and S deficiency, and another one is called antithrombin 3 deficiency. These are two potential conditions that I want you guys to think about. So two conditions for procoagulant activity: factor V Leiden, prothrombin gene mutation. Two particular conditions that can cause a decrease in anticoagulant enzymes is protein CS deficiency and antithrombin 3 deficiency. Big thing to remember are these are genetic causes. So these are something wrong with the actual individual's genetics where they have an issue with these particular types of mutations. So please don't forget that. These are genetic causes of hypercoagulability. There's acquired causes of hypercoagulability that we also have to talk about. Let's talk about that. So what's a potential acquired cause? Whenever somebody's pregnant, okay, they prego, or something that kind of like can mimic pregnancy is potential oral contraceptives that contain estrogen. So OCPs, but again, I'm gonna put here E for estrogen. The OCPs have to contain estrogen. So in pregnancy, or when someone's taking oral contraceptives containing estrogen, there's an increase in estrogen activity. Estrogen actually does like to have an increase in procoagulant activity and a decrease in anticoagulant activity. What is that similar of? Hypercoagulable conditions. So please don't forget that whenever somebody is having high estrogens from pregnancy or OCPs, that increases the procoagulant activity. And that increases the risk of forming clots. Okay? Other conditions is usually malignancies, cancers. Certain cancers have the ability to produce hypercoagulant activity. The mechanisms aren't completely known, but it may be certain factors that are released from the actual cancers. The particular cancers that I really want you guys to remember are lung cancers and pancreatic cancers. These are definitely associated with a high incidence of hypercoagulable activity. And what they think is that it may particularly induce an increase in procoagulant activity, maybe through certain factors that are released from these actual cancers. Okay? So, we have an idea now about certain acquired cases of hypercoagulability. What are some other ones? Some other ones that I really want you guys to remember that will definitely probably show up on your exam. This is a big one, so don't forget this one. In someone who has what's called nephrotic syndrome. Nephrotic syndrome is where they kind of have issues with their glomerulus. They have a problem being able to kind of keep that glomerulus as, selectively permeable as possible. So there's injury to the glomerulus. And whenever there's injury to the glomerulus is responsible for filtering out specific types of proteins and things like that. Generally, you don't want proteins to get filtered across the glomerulus. But whenever there's injury to the actual glomerulus, or particularly the basement membrane, in conditions like nephrotic syndrome, they lose the ability to be able to block proteins from being excreted into the urine. And one of those proteins that get excreted into the urine, unfortunately in nephrotic syndrome, is called antithrombin 3. What did we just say antithrombin 3 is? It's an anticoagulant enzyme. If I'm excreting antithrombin 3, what am I doing? I'm decreasing the functional antithrombin 3 anticoagulant enzyme in my blood. And that is going to increase risk of clots. Okay? What else? You know, there's another condition, really unfortunate condition. It's an autoimmune disease. You potentially can see this associated with somebody who has SLE or lupus, systemic lupus erythematosus. It's called antiphospholipid syndrome. Antiphospholipid syndrome is basically an acquired, but also may have some type of genetic susceptibility genes that are involved where antibodies attack potentially phospholipids. But you know what else they can attack? They can attack particular types of anticoagulant enzymes. I have their names right there for you. Protein C and protein S. These are anticoagulant enzymes. If you actually have antibodies directed against them, you decrease the activity of the anticoagulant enzymes. If you decrease the activity of the anticoagulant enzymes, you increase the risk for clots. The last one that I want you guys to think about is really important as well. You know, someone, let's say they have a potential issue where they have a PE. This is a great example. They have a PE, and the treatment for PE sometimes is heparin. You give them heparin, and all of a sudden they develop more clots. What the heck happened? This is a condition called heparin-induced thrombocytopenia, also known as HIT. And what happens is in HIT is their immune system develops antibodies that are kind of like directed against the heparin, but instead of interacting with the heparin, they interact with particular types of molecules present on the platelets called platelet factor 4. And when it sticks with these, it causes the platelets to want to stick with one another. And when they stick with one another, it causes an increased risk of platelet kind of aggregation. And whenever these platelets stick to one another and they aggregate, it increases the risk of clots forming. And then therefore you develop some clots, you potentially develop a PE as a result of a DVT. Okay? So that covers the hypercoagulable conditions. Let's finish up with the last part of Virchow's triad, which is endothelial injury. All right, last but not least, endothelial injury, right? This is actually probably the easiest one, right? It's the easiest one because you got to cut, you got to injure, you got to damage the endothelium. Surgery, it's obvious, right? Someone goes and does like some type of surgical procedure, there's definitely going to be some type of vascular endothelial injury. So certain types of like C-sections or certain types of orthopedic surgeries, those are potential risks there, right? The other one is smoking. Believe it or not, smoking, which contains the nicotine, some of the other chemicals within inside of the actual cigarettes, the tobacco, have the ability to cause direct cytotoxic injury to the endothelial cells. So that's another particular thing. The other one is obesity. Believe it or not, obesity is a son of a gun. It can actually cause hypercoagulable conditions as well. And not only can it cause compression, causing stasis, not only can it cause hypercoagulability via cytokine release, but also endothelial injury. This can happen because it releases something called interleukin-6 and what's called CRP, C-reactive peptide. And these can actually cause endothelial injury, but also they can cause an increase in kind of a procoagulant enzyme activity. And so they can also cause clots too, so they can be related in hypercoagulable conditions. But obesity is a big trigger for endothelial injury as well. And last but not least, what if I use particular catheters? So I'm using a vascular catheter and I'm inserting it into a vessel. These vascular catheters are definitely high risk for developing particular clots, especially around that vicinity of where the actual catheter is. Okay, so that's a big thing to remember for endothelial injury is surgery, smoking, obesity, which can be involved in all three of these particular aspects of Virchow's triad, and vascular catheters. Now we've covered the causes. Let's start talking about how these causes leads to the pathophysiological mechanism which explains the clinical features of a patient who develops a PE. All right, so let's talk about the pathophys, right? So we have an understanding now about how DVTs, which are the most common cause of someone developing a PE, can develop via the three mechanisms of Virchow's triad. Now, when someone comes in, you have to be able to tie the causes, the risk factors to their clinical features via the pathophys, right? So if someone comes in and you have a high suspicion of a PE based upon the other things that we'll talk about, one of the things to think about is what was the common cause? DVTs. How do DVTs generally present? It's actually relatively simple, right? So let's say here you have a clot that develops inside of a deep vein, right? Maybe it's the popliteal vein, maybe it's an anterior tibial, posterior tibial, whatever. But whenever there's this clot there, usually blood is going to want to flow up through this vessel, obviously, right? But there's an occlusion there. And so what happens is there's some extravasation of plasma into the surrounding area, right? And that can cause some swelling, okay? Also, You can also lead to some redness, okay, because of the actual potential, not just extravasation of plasma, but blood kind of staying localized within that area. So there can be not only just extravasation causing edema, but there can also be a little bit of redness there as well. And because of all that swelling and starting to cause kind of a little bit of a compartment type of syndrome kind of thing, it can cause pain as well. And so before you know it, this could potentially progress to this, where you have a patient who presents with swelling of a lower extremity. They present with pain. They present with redness. But here's a big one to think about. They love to ask this on the exam. You shouldn't do it because sometimes it can actually be problematic, but if you suspect that someone has an asymmetric swelling, pain, redness of an actual lower extremity, you can take and dorsiflex their foot and it should produce a very intense pain. And this is called a positive Homan sign. So this is another thing to think about for a patient that you suspect a DVT. Okay? So they have swelling, pain, redness of an actual asymmetrically of lower extremity and positive Homan sign. Think about a potential DVT. Now, the problem is that if that actual DVT breaks off, embolizes, gets stuck in the pulmonary circulation, what is the complications of this? Well, come on in, baby. Let's see. Let's say that sucker breaks off. Here's the little clot coming up from one of these actual deep veins. It comes up through the inferior vena cava into the right atrium. From the right atrium, it goes into the right ventricle. From the right ventricle, it goes up through the pulmonary tract. And then from the pulmonary trunk, it then can bifurcate and go to the right pulmonary artery or left pulmonary artery, right? And then from there, what can happen? It may get stuck in a vessel within inside of the pulmonary circulation. Sometimes even worse. Sometimes it can actually form a clot right within a big pulmonary artery, one of the right ones, maybe one of the left ones. The worst case scenario is you form a clot right in the center where it actually bifurcates, causing a saddle embolus. We'll talk about those in a little bit. But either way, you're developing a clot somewhere within the pulmonary circulation. How does that affect the ventilation perfusion processes? Let's say that here we have an alveoli that we're going to take and zoom in on and look at. If we look at that where there's a pulmonary capillary and alveolar interface, this is what we get. And generally what happens is whenever you take a breath in, you're bringing oxygen into the alveoli, right? And then that gives you a particular partial pressure of oxygen within the alveoli. If you guys remember, generally the partial pressure of oxygen is generally somewhere around 100, 104 millimeters of mercury, right? And then generally the oxygen that's within the pulmonary capillary blood, usually the pulmonary arterial oxygen is usually somewhere around 40 millimeters of mercury, right? And so you have 100 to 40, generally gradient here where oxygen easily should move from the alveoli into the blood, right? But you have a clot that's occurring right here. Blood is supposed to flow through here, pick up oxygen, drop off CO2, and then exit out as oxygenated blood. But I have a clot now that's blocking the perfusion to this area. So if I'm blocking the perfusion to this alveoli, my ventilation is normal because I can breathe and bring as much oxygen into this alveoli. So this could be normal. But the perfusion is significantly affected. And I'm not actually bringing enough blood to this area to be able to put oxygen into the blood. So effectively, what happens to the oxygen that leaves this alveolar capillary interface? Is it going to be normal oxygen or is it going to be low oxygen? It's going to be low because I didn't have enough blood that was actually traveling through here to pick up oxygen. So not many red blood cells are going to get through here. So the amount of red blood cells that are picking up the oxygen are going to be very, very low. And so generally this is called what? Whenever you have low oxygen in the actual arterial blood. This is called hypoxemia. And so this hypoxemia that we have is actually a result of what? It's a result of not ventilation, right? So the ventilation, it's important to realize this, the ventilation is normal. So that's not the problem. The ventilation is definitely normal. The problem is the perfusion, yeah? So the perfusion, this aspect, is abnormal. And this leads us to this thing called the VQ ratio, right? You guys probably remember that, right? So the VQ ratio, usually you want this to be less than 0.8. The ventilation is up. It's normal. But the perfusion is down. So what happens to the overall ventilation perfusion ratio? Does it go up or does it go down? Well, the numerator is big and the denominator is small. I think it goes up. Yeah, so it does. So this causes an increase in the ventilation perfusion ratio. We translate that into what's called an increase, and this they're going to ask you this probably on your exam, an increase alveolar arterial gradient. Okay? Meaning that there's more oxygen within the alveoli and very little oxygen within the arterial blood. Okay? So we have an understanding of this, okay? Result, hypoxemia. Why is the hypoxemia problematic? Well, hypoxemia is going to cause low oxygen saturation. So whenever you actually look at this person's O2 sat, it'll be low, potentially. The problem with hypoxemia is that hypoxemia can potentially activate very specialized receptors that are located within our aortic bodies and carotid bodies. You know, there's like these little chemoreceptors located here, and then they're also located over here. They're called carotid bodies. They're little chemoreceptors, and they pick up the concentration of oxygen. Whenever the oxygen concentration is low, hypoxemia, it stimulates these chemoreceptors. So what are these called? They're called chemoreceptors. If you really want to be special, which types of chemoreceptors are they? Are they peripheral or central? They're peripheral chemoreceptors, right? And these are called, they're within the carotid bodies and the aortic bodies. What happens is when they're stimulated, they're connected to particular cranial nerves. Do you guys know what cranial nerves these are connected to? These are connected to cranial nerve 9, which is going to be your glossopharyngeal nerve. And they're also connected with cranial nerve 10, which is your vagus nerve. And what happens is these guys will pick up any kind of sensation of altered oxygen and send that to your brainstem. It'll activate particular breathing centers within the brain and say, hey, oxygen is low, buddy. I think we need to try to breathe faster or something so that we can bring more oxygen into other alveoli that are working well and are perfusing well, and so that I can try to get my oxygen up. And so what it does is it tells the actual medulla, say, hey, start increasing the breathing rate. And so what happens is, as a result, you're going to increase the stimulation of your intercostal nerves, your diaphragm, and what happens as a result? You increase your respiratory rate and depth. As you increase your respiratory rate and depth, you're trying to breathe faster. The whole goal is that you'll bring more oxygen into the alveoli, and then the whole thought is that if you bring more oxygen into the alveoli, into the ones that are perfusing properly, you'll get oxygen into the blood and fix the actual hypoxemia. But you know what actually ends up happening as an unfortunate result? Because there may be a very significant perfusion deficit, and you can ventilate all you want, it may not fix the hypoxemia. Instead, what it may do is if you breathe faster and deeper, not only are you bringing in more oxygen, but guess what else you're getting rid of? CO2. And so you're starting to exhale out lots and lots of CO2. So what happens to the concentration of CO2 within the blood? So what is this called whenever you have an increase in respiratory rate and depth? It's tachypnea, right? So this is going to produce what's called tachypnea, which is an increase in the respiratory rate. You're going to try to bring more oxygen in to offset the hypoxemia, but unfortunately, as a result, you actually blow off more CO2. So what happens is, if you get rid of more CO2, what happens to the CO2 levels in the blood? The CO2 levels in the blood go down. What is that called when the CO2 levels in the blood go down? Hypocapnia. What happens to the pH? You guys remember pH and CO2? What's the kind of relationship between these? If CO2 goes down, it should be inverse for pH, right? pH should go up. So, as a result, you can develop what's called a respiratory alkalosis. That's a result of their tachypnea, them breathing faster and deeper, okay? And this is, again, usually because of what's called hypocapnia. You're breathing off all of that CO2, dropping the amount of CO2 within the blood. Now, that's one of the mechanisms here, right, that we're going to try. So first and foremost, a person will have hypoxemia, may present with a low pulse ox on their actual pulse oximetry. They may also have signs and symptoms of a DVT. Then they may breathe faster. They may have tachypnea. You know what else is interesting? Is not only does this sympathetic mechanism increase to cause increase in respiratory rate and depth, but you may also, from this hypoxemia, you may also get an increase in heart rate. And the whole reason why is whenever you're hypoxemic, the thought is that, okay, there's less oxygen maybe that's either not being ventilated. I'm going to fix that by breathing faster, but I'm going to increase my heart rate, which should increase the cardiac output. I should push more blood to the alveoli, and hopefully that will increase my oxygen as well. So that's kind of the whole process by which that will occur. So they may have tachycardia, tachypnea, respiratory alkalosis on their ABG, hypoxemia presenting as a low pulse ox. What's another clinical manifestation of hypoxemia? Please don't forget this. Let's write this down. I actually should have told you guys this a second ago. But if a person maybe has a normal pulse ox, or they have hypoxemia in general, this can present as dyspnea. So shortness of breath. Okay? So remember, if a person presents with symptoms of dyspnea, hypoxemia, tachycardia, tachypnea, respiratory alkalosis, you start having some ideas of a pulmonary embolus. Okay, what else is potential clinical features of this? All right, let's say here you have we're going back to this pulmonary vessel, we're just zooming in on it. Okay, we're zooming in on this portion right here. Okay, so here's our clot within that pulmonary vessel. Okay, and within this clot, you have a bunch of platelets. You know, platelets, whenever they're sticking and they're forming a clot, they're sometimes a little bit mean. But they're smart sometimes. It's a mean reaction. They start saying, hey guys, let's start secreting a bunch of different enzymes. So there's the clot, right, containing lots of platelets. They release 3 particular chemicals: ADP, thromboxane A2, and what's called 5-hydroxytryptamine, also known as serotonin. These 3 chemicals do a couple things. The first thing that they do is they act on the bronchial smooth muscle, stimulate the bronchial smooth muscle to undergo contraction. Whenever the bronchial smooth muscle undergoes contraction, what is this called? It contracts and narrows the airway. It's called bronchoconstriction. So this can induce what's called bronchoconstriction, which can worsen their already present dyspnea. Okay? The other thing is that these chemicals also induce vasoconstriction of the pulmonary vasculature. So what else is going to happen? It's going to cause pulmonary vasoconstriction. And the problem with this is, when you cause this pulmonary vasoconstriction, why are we trying to pulmonary vasoconstrict these vessels? It's very interesting. It's an interesting mechanism. The whole thought behind this is this. Here you have this alveoli that's ventilating properly. It's getting oxygen. But the issue is that the blood vessel that you're actually trying to send to this alveoli has a clot in it. And so this alveoli is unfortunately a waste of time. So what I actually want to do is clamp down on this vessel and send blood to a nearby alveoli that actually would be able to participate in the gas exchange process. And so what happens is it undergoes a pulmonary vasoconstriction mechanism here, and the attempts to shunt blood through the other pulmonary vessels where gas exchange will actually occur. Okay? So it's trying to enable the alveoli to particularly allow for gas exchange to occur within alveoli where the gas exchange is actually going to be efficient and not having this issue because of a pulmonary embolus or clot. The problem with this is that if you pulmonary vasoconstrict vessels, that can put stress on the heart, and we'll talk about how that does that in a second. But the other thing that this pulmonary vasoconstriction can do is it can decrease oxygen supply to the lungs. Now the lungs has a dual blood supply. It has the bronchial blood supply, and then it also has the pulmonary artery supply. Sometimes, if a patient develops a severe kind of like pulmonary vasoconstriction and you decrease oxygen supply to the lungs, it could lead to an infarction of the actual lungs. And if that occurs, sometimes it can cause a rupture within the alveolar capillary membrane. Blood can leak into it, and then whenever you cough, you start coughing up not just material within the airways, but the actual bloody material that occurred from the rupture. And this can present with what's called hemoptysis. So they can present with respiratory alkalosis, tachypnea, tachycardia, dyspnea, representative of their hypoxemia, bronchoconstriction, which can worsen dyspnea, pulmonary vasoconstriction, which can put stress on the right side of the heart, also can decrease oxygen supply to the lungs. You usually have a dual blood supply, so this doesn't happen too often, but if there's a significant amount of oxygen deprivation to the lung tissue, they can undergo infarction, they can disrupt the alveolar capillary membrane, blood cells can actually start leaking in, and then whenever you cough, you can develop the hemoptysis process. Okay? All right. Here's another thing that we got to talk about. One more. You know, whenever somebody has this kind of clot, okay, within inside of the pulmonary capillary system, it causes a lot of pain, okay? And this pain is very intense sometimes, but the pain is very specific, and it's very important to remember this. The pain that these patients usually develop is what's called sometimes like a pleuritic chest pain. So sometimes the pain that they get is another big thing to remember is what's called a pleuritic chest pain, meaning it's pain that occurs particularly whenever they're breathing. So another potential clinical manifestation of these patients is not just dyspnea, hypoxemia, tachypnea, tachycardia, as well as potential hemoptysis, but also pleuritic chest pain. Here's usually the most devastating aspect of the condition. If you get one of these saddle emboli, okay, or a very proximal like pulmonary artery embolus, that is going to put a lot of stress on the right side of the heart. So here's the clot, right? And it's restricting blood flow, right? So now I have very little blood that's actually moving through this vessel. What happens to what's called the systemic vascular resistance in this vessel? It goes up because it has a very small diameter. With small diameter, there's more resistance to blood flow. So what happens is you get an increase in the systemic vascular resistance. When you increase systemic vascular resistance, you increase afterload, but you also increase the blood pressure. But in what system? The pulmonary system. So now the pressure inside of this pulmonary system here is much higher. The pulmonary system isn't usually very high. It's a very low system. But as you have this increased systemic vascular resistance, increased afterload, and higher pressure, now this poor little right ventricle's got to work so hard against that high afterload, against that high blood pressure. And so you know what happens is the right ventricle starts really getting stressed out, and it just geeks out. Unfortunately, it's going to become so difficult. So what happens is the right ventricle undergoes dilation. Then it undergoes right ventricular dysfunction, where it's having to work so hard to be able to pump blood against this high pressure that the stroke volume and the cardiac output just goes down, unfortunately. So you know what happens as a result? Because of this right ventricular dilation and right ventricular dysfunction, there is a decrease in stroke volume. Therefore, there is a decrease in cardiac output. You know the problem with that is the blood that goes from the right ventricle, where else does it go? The blood from the right ventricle will go to the pulmonary circulation and then come back through the pulmonary veins to the left side of the heart. So if I have a decreased stroke volume and decreased cardiac output from the right side, that's going to lead to a decreased preload to the left ventricle. And so now the left ventricle, focusing on the left ventricle, will have a decreased preload and a decreased stroke volume, a decreased cardiac output, and therefore a decrease in blood pressure, hypotension, systemic hypotension. That's a problematic issue there. We'll talk about the reflexive events there, but here's another thing. If the pressure in the right system is so high and blood isn't able to get out, you're having less blood get out, where is the blood going to start backing up into? The right atrium. And when it backs up into the right atrium, guess where it can go? Up the right atrium, up through the superior vena cava. And you know what that leads to? Whenever it goes back up the superior vena cava, it goes up via the jugular vein. And the jugular vein starts getting all puffy. What is that called? Jugular venous distension. So they may have what's called JVD. One more thing. If the pressure within inside of the right ventricle is so high and it starts getting dilated, it might start shifting and encroaching that interventricular septum into the actual cavity of the left ventricle. And if you start kind of obstructing the left ventricular cavity, what happens to the left ventricular outflow tract? It gets obstructed. And so the left ventricle can't pump as much blood out. So another thing here that can happen as a result is not just a decrease in cardiac output because of a decrease in stroke volume that's affecting the left heart, but another thing is that the interventricular septum may be kind of bowing in and occluding into the lumen of the left ventricle. And that's kind of increasing the left ventricular afterload as well. So another effect that you may get here that causes the hypotension is the left ventricular afterload effect that increases. Okay, we got JVD. We got a right ventricular dysfunction, right ventricular dilation, high stress, hypotension from the left side of the heart. Okay, next thing. Hypotension is a problematic issue, right? That's not a good thing. What your body tries to do in response to this is you have little receptors similar to the chemoreceptors. They're here in the carotid area, and they're here in the aortic area, and they're here in the carotid area. These are called your carotid sinuses and your aortic sinuses. These are baroreceptors. And these baroreceptors, they pick up changes in particular pressure. So whenever the pressure is low, it's going to tell these baroreceptors. The baroreceptors will send that information of low pressure via cranial nerve 9 and cranial nerve 10 to the medulla. Let the medulla know, hey, blood pressure be low, homie. You got to do something about this. And you know what the medulla says? He says, don't worry, I got you. I'm going to try to do a couple things to try to get the blood pressure up. I'm going to try to increase my sympathetic system and increase the heart rate. And so what happens is they develop what's called tachycardia. The whole goal behind that is that if you increase heart rate, you should increase cardiac output, it should increase blood pressure to fix that issue, right? The other thing it says, I'm going to increase contractility. Okay, and that hopefully the increase in contractility will increase the blood pressure. It's not going to do too good though, because it's got very little blood coming from that right side of the heart, and it's got that right ventricle kind of bowing in. So that might not help. And the last thing it does is it tries to undergo vasoconstriction of like peripheral vessels. And so the vasoconstriction of peripheral vessels try to increase your systemic vascular resistance and increase your blood pressure that way. And that might help a little bit. So again, to summate everything we talked about with the clinical features associated with the pathophysiology, you can see a patient coming in with symptoms of DVT, right? So you want to think about potentially any kind of swelling, any kind of pain, any kind of redness, any positive Hohmann sign associated with a DVT, right? We also want to say, okay, do they have any pleuritic chest pain? Do they have any signs of dyspnea or any hypoxemia that we see on their pulse ox? Okay? Do they have an increase in respiratory work or depth that's in the sign of tachypnea? Are they trying to compensate for that with an increase in their heart rate as well? On their ABG, do we see signs of early respiratory alkalosis, maybe a little bit later as they start to tucker out from having to breathe this fast? They may develop respiratory acidosis. The other thing is there any signs of coughing or coughing up of blood from significant pulmonary infarction, from a decreased blood supply, and hemorrhage of particular alveolar capillary membrane in the form of hemoptysis? Is there any signs of JVD due to right ventricular stress, like in dilation and dysfunction? Is there any other signs of right ventricular stress in the form of decreased blood flow to the left ventricle, causing hypotension because of a drop in their preload, and then them creating a reflexive tachycardia in response to that? So these are some of the big things that I want you guys to think about. Now that we've covered that, let's start getting into the diagnostics. All right, engineers, so now let's talk about the diagnostics. We're not gonna go too crazy on like all these different things, like unnecessary like lab testing. We're gonna get down to like the most important things that you really need to know for your exams and clinically on the ward. So what kind of labs could we order? You could really do a lot of labs. You can always get a CBC, you can get a CMP, you know, but and all of those are great things. You can get an ABG. We kind of have an idea of what it's going to tell us, right? So if we were, let's say, get some labs, you can get a CBC. The CBC may help you to kind of look at underlying etiologies, like maybe they have HIT, right? Maybe they have heparin-induced thrombocytopenia. Maybe they have, you'll see that with low red blood cells and low platelets. That's fine. You can get a BMP, I think a BMP is good. The reason why is if you give contrast to a person, potentially if they have a significant like renal dysfunction, like a very, very, very low GFR, there is risk of worsening that via what's called a contrast-induced nephropathy. So getting a BMP, if you're going to do some of these studies, may be a good idea to get a good idea of what their renal function is. The other thing that we can get is what's called an ABG, and we already have an idea of why we can get an ABG. The ABG will tell us what? If the early stages of the PE and they're trying to breathe off their CO2 by increasing their ventilation to try to bring more oxygen in, they have a respiratory alkalosis. If it's a little bit later, as they're starting to tucker out eventually, because they've been breathing so fast and their muscles are getting weak, they might start developing what's called a respiratory acidosis. So again, we might see them in two different stages there. The other test that I want you guys to realize, and we're going to talk about this one here, is called a D-dimer. Okay, it's an okay test. I think it's a good test if you have a very, very low pre-test probability. You can do this test, and we'll talk about the algorithm that I really want you guys to remember out of this. Is what the big important thing for diagnostics is the approach. But really, really quickly, let me talk to you about D-dimers. D-dimers, what they're helpful for is telling us an activity of fibrinolysis, right? So it tells us about somewhat of a clot burden, also kind of inflammatory activity in general. So let's say here we have a clot, right? Generally, in this clot, we have natural enzymes. You know, there's an enzyme called plasmin. Plasmin naturally wants to break down the actual fibrin within the blood clot. You know, fibrin is made up of fibrinogen. And fibrinogen contains these little D segments, these little D structures within it. Okay? And whenever you break down fibrin, you can break it down into what's called these fibrin degradation products, and one of them are called D-dimers. Now imagine you have a big clot here. You're going to have more plasmin activity trying to break down that clot. You're going to be breaking down more fibrin, making more fibrinogen degradation products and more D-dimers. So the thought behind checking a D-dimer is telling us that there is a big clot burden and that there's a lot of plasmin enzyme activity that's naturally trying to break that down and dissolve the clot. That's kind of the indication. So you can say, ooh, big old clot burden. Is the D-dimer elevated greater than 500? Maybe there's a potential for a clot somewhere like a DVT or a PE. Okay? Now that we understand that, you can get a CBC, you can get a BMP, you can get an ABG, you can get your D-dimer. When do we get the D-dimer? You shouldn't always get a D-dimer. Let's talk about when you get a D-dimer and when that's not even going to matter, and there's more particular tests that you should be utilizing for diagnosis, and then adjunctive tests which may help you, but also you just got to know it for your exam. So the first thing is, let's say that you have a high suspicion of a PE, right? So we're thinking that you got a PE. Or let's say that you just have a PE, you have a suspicion of a PE. You're not quite sure if you have a high suspicion or a low suspicion yet, right? So you just think, oh, maybe a PE. All right, so don't bother memorizing every single aspect of the Wells criteria. You have these things called like MD Calc, which you can kind of just utilize to get yourself a score. I'd rather you just know that this score exists for determining your pre-test probability for PE. So if you have a high Wells criteria score, you have a high suspicion of a PE. If you have a low Wells criteria score, then you have a low pretest probability or suspicion of a PE. It just helps you in that sense. Don't memorize every single component of it. So once you've gotten your Wells criteria, which you can get on like MD Calc, you get scores out of this, right? The newest one, the most recent like modified Wells score, is we go based upon a number that if it's less than 4 or greater than or equal to 4. Okay, so less than 4 or greater than or equal to 4. If it's less than 4, a PE is unlikely. And we say this another way is that you have a low pretest probability. It's not a very, very high chance that they have a PE. But to be on the safe side, let's see if they have some high clot burden, they have a lot of fibrinolysis going on naturally. So how do I do that? I check a D-dimer. If the D-dimer is very low, generally we say like less than 500, so here we'll put less than 500, you can say that a PE is excluded. Okay? So some type of VTE or PE is excluded. Now, if it's greater than 500, greater than or equal to 500, then there's somewhat of a higher suspicion. And so we may do another test. Now, we'll get to what that test is in just a second because we're going to move down that way, right? So again, Wells criteria score, less than 4, PE unlikely, low pretest probability, just check a D-dimer. See if there's a high clot burden that's going on. If it's not, you can exclude a PE. If there is, you have to be compelled to potentially order another test. Now, if the Wells criteria score is greater than or equal to 4, now your pretest probability is higher. And so the PE is more on the likely side. So because of that, we don't waste our time with the D-dimer. We go straight to the definitive diagnostic test, which is a CTPA, which is a CT pulmonary angiogram. It's just basically you give them contrast, and that's why you maybe want to get a BMP to check their kidney function. You're giving them contrast because it's going to light up those pulmonary vessels and look to see if there's any kind of like filling defect or clot in that circulation. A big thing to remember, let's do this one in pink so that you guys don't forget, is that CTPA, sometimes, let's say, you can't get this done, okay? So there's, let's say there's a contraindication to it. For whatever reason, let's say you have a very severe, like you get contrast allergies, you go into like full-blown anaphylaxis, or you have just severe CKD with a very low GFR, and you're at high risk for a contrast-induced nephropathy. Okay, those kinds of situations, you might not be able to get a CTPA. In those scenarios, what they usually go with, an alternative, is you do what's called a VQ scan. And we'll talk about that a little bit later, okay? So an alternative to a CTPA in those circumstances may warrant a VQ scan. Now, PE likely, based upon the score, you get a CTPA. Or PE unlikely, based upon the score, D-dimer elevated, you get a CTPA. CTPA is done if it is normal. This should be in red. If it is normal, then what does that tell us? That means that there's no clot. There's no kind of like blockage within the pulmonary circulation. So if there's no blockage within the pulmonary circulation, what can we say then? It's unlikely that there is a PE. So a PE can be excluded. Okay? Now, what if you get a CTPA and it's indeterminate? You can't really, it's not conclusive enough. You don't have a clear enough idea whether or not they truly have a clot within the pulmonary circulation. So this is referred to as indeterminate. Okay? Indeterminate. Now, in that kind of situation, when it's an indeterminate study, you have no idea if there's truly a PE, the next thing, which is a very invasive test, what you can do it is you can get what's called a pulmonary angiogram, where they actually put a catheter that runs down into the right atrium, right ventricle, and then you throw contrast into the pulmonary circulation and light it up. Okay. Another option is they do what's called a lower extremity venous ultrasound, because again, what is the most common cause of someone developing a PE? A DVT. So if you find a positive DVT within the lower extremity, you can also say, a good chance it's a PE, and they can anticoagulate. Now, if it's positive, if they definitely have a clot, then you go and you treat a PE as the diagnosis, okay? So we have a good, I think, idea here of how to approach a patient that we have a suspicion of a PE based upon all the things that we talked about. Now that we've done that, let us take a look here at the different tests, what they would look like. What are some of the things that I want you guys to be keen on through some of these actual images? Let's go ahead and take a look at these. All right, engineers, so let's go ahead and take a look at the gold standard diagnostic test. It's the biggest one that I want you guys to be able to recognize for pulmonary embolism, and that is a CTPA. So here we're going to take a CT, and we're just looking at the pulmonary arteries when they're getting filled with IV contrast. Okay, so let's go ahead and take a look here. We're in the abdomen right now, so let's come up into the thorax. A big quick orientation of a CT is that you're looking at the CT from the feet towards the head. So this is actually the right side of the patient's thorax, and this is the left side of the hemithorax. And then here we have the heart, right? And the heart always points towards like the left side. All right, now as we continue to kind of scroll through here, we're going to move our way up. we want to focus our attention on the pulmonary trunk. So as you can see here, the pulmonary trunk is where we're going to have this bifurcation. So look, right there is our pulmonary trunk. So this is going to be coming from the right ventricle, pulmonary trunk right here. And then as we move this way, we're going to be moving right pulmonary artery. And as we divert this way, left pulmonary artery. It should all be white. But look what I'm seeing here. I'm seeing some kind of like darkness right here in that right pulmonary artery. That's a clot. That's actually an embolus. And then look over here in the left pulmonary artery. Boom, another embolus in the left pulmonary artery. This patient is all jacked up. They got bilateral pulmonary emboli that we can see on their CTPA. So this gives you an idea of what it would look like. So to kind of summate what we have here for this patient, boom, we have this patient showing signs of a bilateral right and left pulmonary emboli on evidence of the CTPA. Now let's take a look at the alternative test that we can utilize called a VQ scan. All right, engineers, let's take a look here at a VQ scan. So a ventilation perfusion scan, we utilize kind of an element called technetium, and it helps us to light up on this actual ventilation perfusion scan. So here on the right, this shows ventilation. So you're seeing the technetium getting inhaled and ventilating all of the alveoli in the right and left lung. But then we get to see what happens for the perfusion image here on the left. So as you can see, there's perfusion deficits here in this aspect of the lower part of the right lung, and even here in kind of the middle and lower part of the left lung. So we know that there's potentially some pulmonary emboli that's occluding perfusion to these segments of the lung. So we see a ventilation perfusion deficit, particularly here, more particularly on the end of the perfusion deficit. So again, what does this VQ scan tell us? But bam, ventilation is normal in this patient, but we have some perfusion deficits that are occurring here in these two lobes of the lung on our VQ scan. All right, now let's take a look at our pulmonary angiogram. All right, engineers, let's take a look here at a pulmonary angiogram. This is a very invasive test. It is actually the most definitive diagnostic test, but it shouldn't be done because of it has, a lot of risk because it is an invasive study. But you're basically taking a catheter and filling contrast through the pulmonary arteries. And when you do that, you should see it kind of light up nice and black where all the contrast is filling. You can see it pretty well here on that right lung, but you notice how there's kind of like a deficit or kind of like a filling defect. At this point where they fill the contrast, there isn't any contrast coming down into these lower dependent segments. So we can potentially say that there may be a filling defect here in this left kind of lower segment here where this pulmonary artery may have an emboli. So let's go ahead and take a look at what we would see as our label here, but boom, there is a filling defect here in that left lung, potentially secondary to an emboli that's kind of within this portion of that left pulmonary artery. All right, so that takes care of our pulmonary angiogram. Let's take a look now at an EKG of someone with a pulmonary embolism. All right, engineers, let's take a look here at an EKG for someone who has a pulmonary embolism. Again, one of the most common findings, we're not going to look at it here on this one, but one of the most common findings on an EKG for a person with a pulmonary embolism is sinus tachycardia. But on your exam, what are some things that you really need to be thinking about? So there's what's called an S1Q3T3 pattern. So you look at lead 1. If they have a very deep S wave, that's the S1 component, all right? Then you look at lead 3. They have an inverted T wave here in lead 3, and then a Q wave, a deep Q wave in lead 3. So there's an S1, Q3, T3. The other thing is your axis. Sometimes they may have what's called a right axis deviation. Use your thumbs. Your left is going to be for lead 1, and your right thumb is going to be for AVF. Which one's actually going to be doing here, right? So lead 1 is pointing down, AVF is pointing up, so my right thumb is pointing up, so it's a right axis deviation. The other thing is look here in V1, V2, V3. It has that bundle branch kind of pattern, right? RSR prime pattern. So there's a right bundle branch block here. So S1, Q3, T3, right axis deviation, and a right bundle branch block. That is going to be what we would see. So take a look here at our EKG, but boom, S1, Q3, T3, classic sign, right bundle branch block, and then we also have right axis deviation. All right, that's our EKG. Now let's take a look here at the next, which is the echo. All right, engineers, let's take a look here at an echo. This is actually one of my favorite tests that I love to do on patients who I suspect has a pulmonary embolism. It's something that you can do with ease at this bedside. So what I want us to do is to actually point out some of the structures, get a little bit of orientation down here. So let's actually kind of scroll through this nice and slowly here. A couple of things that I want you guys to see here. On this side right here, this is actually the left ventricle. This is your left atrium. So you have some valves here. This would actually be your mitral valve. over here, this is actually going to be your right atrium, and this is your right ventricle. And then over here, you'll see kind of a dark anechoic structure. That'll be the inferior vena cava. Now, what I want us to notice here is that in someone who has a PE, the right ventricle will be dilated and it'll be dysfunctional. It won't be contracting very well. And the right ventricle can be bigger than the left ventricle. And on top of that, the inferior vena cava may be a little bit plumpier than usual. So let's take a look here and actually scroll through. Look at the left ventricle for a second. Look at how well it squeezes. It squeezes super well. Now compare that to the right ventricle as I'm scrolling here. It's not really making much of a really good squeeze. So there's a little squeeze there in comparison between the left ventricle and compared to the right ventricle. And if you look up towards that left side, you see that big anechoic structure is the inferior vena cava. It's relatively dilated, and the right atrium is also a lot bigger too. So there's a lot of right-sided pressure. And again, this is a classic signs of a pulmonary embolism. So dilated right ventricle, very decreased hypokinesis of the right ventricle, bigger than the left ventricle, and a dilated right atrium with a dilated IVC. These can be signs of a pulmonary embolism on echo. Now let's take a look at the lower extremity venous ultrasounds. All right, engineers, let's take a look here at seeing if there's any kind of signs of DVT, which may be kind of a prelude to why the person has a pulmonary embolism. So I just took and did a quick ultrasound on one of Rob's legs to kind of show you what a compressible vein should look like, because that's one of the big signs. Sometimes you can see a fresh clot within the vein, but one of the big things is compressibility of the vein. So if I play this video here, you can see I'm going to push down on the probe on his leg, and you see that it actually collapses the vein. So that is a good sign. That means that there is no kind of evidence of a thrombus that's actually blocking the compressibility. Now, let's take a look at someone who actually has an abnormal kind of compression ultrasound sign, and that it doesn't actually collapse this vein here. So here's the vein on this patient, right? And this would be one of the arteries. So this is actually going to be the femoral vein, and this is the femoral artery. And what we're going to do is we're going to look here, watch as this does not actually show any signs of compression. Ready? Boom, it should have compressed. It did not compress. So again, if we look here, we're going to squeeze. No compression there. You actually don't see any signs of a fresh clot, but again, there's no compression of that femoral vein. It should collapse when you compress down on it. So that's a common sign of a DVT or a clot within inside of this actual deep vein. All right, that covers our imaging. Let's go ahead and take a look at a chest X-ray back on the whiteboard. All right, so the last thing I wanted to talk about now that we've taken a look at all these images is another thing to be thinking about, a really big thing, a big clue, okay? Is that if a patient comes in, you have a high suspicion of a PE, they're having some symptoms of shortness of breath, you get a chest X-ray because you want to rule out other kinds of causes. A big clue to think about someone having a PE is if you obtain a chest X-ray, the most common finding is that it's normal. And that should cue you in if a person has some of the symptoms that we talked about above and they have a normal chest X-ray, be having a high suspicion about PE. Now, on your exams, there's these classic findings that you don't really see, but you should know about them. Sometimes what happens is if you get a clot within the pulmonary circulation, like a pulmonary vessel, the tissue that it's supposed to supply maybe start undergoing avascular necrosis and can show a dark hyperlucent area. That dark hyperlucent area that's actually distal to wherever there was a clot was is called Westermarck's sign. Okay, so it's a sign of where there is a cutoff of a pulmonary vessel causing a hyperlucency on the actual chest X-ray. The other one is sometimes you can get this wedge-shaped opacification, and that's due to pulmonary infarction. And so if there's a wedge-shaped kind of opacity, and there's what's called a wedge-shaped infarction, that can be called a Hampton's hump. These are things that you really don't classically see, but they're things that you should know for your exam. Okay? Now that we've covered the diagnostics, let's talk about the treatment of PE. All right, so let's talk about the treatment of PE. So it's actually not that bad, believe it or not. So treating a PE, okay, first thing you have to do is determine their hemodynamic status. Because then once you determine their hemodynamic status, it takes you down the algorithmic pathway of what to do. All right, so first things first, you have a PE that you have diagnosed. The next thing you say is, okay, what's their hemodynamic status? If they are hemodynamically stable, what do I mean by that? Well, if you guys remember the pathophysiology is that they could be very, very tachycardic, they could be severely hypoxemic, And they could even have hypotension, jugular venous distension. So those are signs of hemodynamic instability, right? If that happens, okay, or they're not actually perfusing the brain, so they develop like an altered mental status, that's also another thing, or it's very, very severe pleuritic chest pain. In those kinds of situations where they're very, very hemodynamically stable, more specifically, significant hypotension, significant tachycardia, significant hypoxemia, those are things to think about. And this person, they don't have that. So we don't have to go with the very aggressive therapies. We can go with a little bit of the less aggressive therapy. And we have two options. The first one is that we can do what's called anticoagulation. And there's different types of anticoagulants that we will discuss in great detail. Now, if they have a contraindication to anticoagulation, so we'll put AC, then we do what's called an IVC filter, okay? Simple as that. Hemodynamically stable, diagnosed with a PE, you can do what? Anticoagulation if they have a contraindication anticoagulation, or for some reason anticoagulation is unsuccessful, you do an IVC filter, right? Done. If they have a PE and they are hemodynamically unstable, now what do I mean? They're severely hypotensive, they're severely tachycardic, they have very bad hypoxemia. These are potential signs of hemodynamic instability. That leads us to the next question, which you may actually see in your exam, so let's quickly discuss it, is there is definitions of PEs and the grading of their severity. So we have what's called a submassive PE. A submassive PE is you have a PE within the pulmonary circulation, but they're hemodynamically stable. They don't have any severe hypotension, they don't have any severe tachycardia, but they have right ventricular dysfunction. And this kind of scenario, you might lean more to the anticoagulation of the IVC filter. If someone has the other end of the spectrum, which is a massive PE, usually this is what's called a saddle embolus. And again, remember I told you saddle embolus is? It's basically when there's a clot in the pulmonary trunk. I'll show you that when we get down to this other diagram. But in this situation, they are hemodynamically unstable. They're hypotensive, severely tachycardic, severely hypoxemic, and they have right ventricular dysfunction. And again, usually this is a saddle embolus, so they have evidence of a very significant kind of clot burden within the pulmonary circulation. So in these kinds of scenarios, your massive Ps where they're more hemodynamically unstable, you might opt to these treatments. What are those treatments? The options that you have here is that generally you can give something called TPA, tissue plasminogen activator, to help to bust open that clot. But if they have a contraindication, look how easy it is. It was just the same thing for this one. If they have a contraindication to TPA, then you go with something called a embolectomy. Done. So now we know a person has a PE. We determine their hemodynamic status. If they're hemodynamically stable, they got right ventricular dysfunction, they got a decent clot burden, we might have a submassive PE. I might lean more towards the area of giving them anticoagulation of contraindication, IVC filter. If they have a massive PE, they're hemodynamically unstable, they got a saddle embolus, they got a very heavy clot burden, and they have right ventricular dysfunction, I might lean more towards my thrombolytics or contraindicated embolectomy. Now that we know those things, let's talk very briefly about what type of agents that we would use and like other potential things that you need to know that are high yield. All right, so anticoagulation. I don't want us to talk too much about this. We already have a video if you guys want to, discussing each one of these in great detail. But heparin, okay, heparin is a really good kind of drug that we can use to treat patients who have PEs. Now there's two different types that I do want you guys to know. There's what's called unfractionated heparin, and then there's what's called low molecular weight heparin. What I really want you to know about these is unfractionated heparin is going to be more for like your hospitalized patients, okay? Because this is the one that you do like a drip, okay? You do an infusion. And then when you infuse this, you titrate the infusion, okay, per what's called their PTT, their partial thromboplastin time, which is a measure of the activity of unfractionated heparin to determine if the PTT is too high, there's too much heparin. You got to lower the dosage. If there's low PTT, then you're not actually having enough of the unfractionated heparin, and you got to increase the dosage. So this is ease of titration. You have to have PTT monitoring though to give this, and there is a risk of HIT, hot heparin-induced thrombocytopenia, with this and compared to low molecular weight heparin. With low molecular weight heparin, this is good for outpatient use. So you can use this as an outpatient medication, and it's usually a bridge. So you give this as a subcutaneous injection, okay, as compared to an infusion with unfractionated heparin. You give this as a subcutaneous injection, usually as a bridge for like a couple days, and then you start them on one of these two agents over here for long term for like 3 to 6 months. Okay? The only thing to think about with low molecular weight heparin is there's no PTT monitoring, and you don't even need the what's called XA activity. The only thing to be wary of with this one is if someone has renal failure. So if they have severe chronic kidney disease, you may have to either renally dose this medication or potentially opt for another medication. So just be cautious in that scenario. DOACs, your direct oral acting anticoagulants, okay? These are great, again, kind of that you'll do these, okay? These are generally kind of like outpatient, like long-term kind of things that you'll do for about 3 to 6 months, okay? And again, we're not gonna go through all of these, but you have your 10A inhibitors, which consist of rivaroxaban, apixaban, edoxaban, and then you have your 2A inhibitors, which is your dabigatran. Okay? Again, these are good drugs. They're actually preferred over warfarin because of a less risk of hemorrhage, and also you don't have to have as much monitoring with DOACs as compared to warfarin. There's less drug interaction, so a little bit superior when it comes to those. Okay? Warfarin, the other thing is, same thing, you can continue this outpatient, and you can do this for about 3 to 6 months. And again, usually you're bridging them with some type of heparin. Heparin into the DOAC or heparin into the warfarin. Especially for the first 5 days when someone's on warfarin. Warfarin is actually hypercoagulable in the first couple days. So you definitely want to bridge them with some low molecular weight heparin or unfractionated heparin, and then continue this. The only big thing that you have to remember is with warfarin, you have to keep monitoring their INR. Okay, because if you have too much warfarin, their INR can be super therapeutic and they have an increased risk of bleeding. Okay? So that's our anticoagulation. We have a good idea now, right? What's the next thing? Okay, if we have a contraindication to anticoagulation, then we got to come down here now and talk about the IVC filters. So if they have a contraindication, they can't get that anticoagulation, then what we have to do is we take and put this little, it's like a sieve basically, right? It's like a sieve. And so what happens is, like blood plasma and small solute particles will be able to pass up through this structure, this little IVC filter, via the inferior vena cava and into what's called the right atrium, right? Into the right side of the heart. Because effectively, this inferior vena cava IVC will then pass blood where? It's effectively kind of doing like one of these things, coming up from the IVC into the right atrium, right ventricle, pulmonary circulation, right? So if we give them this IVC filter, it's designed to be able to block any kind of clots coming up from a DVT and propagating into the actual pulmonary circulation. So again, generally, this is if there is a contraindication to anticoagulation or anticoagulation failed. This brings me to one other thing that I really want to make sure that we understand actually. So let's come up for just a second because I really want to make sure that we understand this. Sometimes it might be misconstrued. Anticoagulation, these medications are not busting open this clot. They're not breaking open the clot. They're preventing the further development of the clot, the propagation or enlargement of the clot. They are not breaking down the clot. That is the job of thrombolysis or the job of an embolectomy. So when you compare these two, IVC filter, it's not breaking up a clot. It's preventing the further development of pulmonary emboli from a DVT. Same thing with the anticoagulation with heparin, DOACs, warfarin. All they're doing is they're basically augmenting our coagulation cascade in a particular way that it prevents the activity of hypercoagulable states or forming clots, and therefore preventing further development or propagation of the clots. Okay, now that we've got that done, We've covered the hemodynamic stable side. Now we got to cover the unstable side. It's really simple. Thrombolysis, if they're hemodynamically unstable, you give them the TPAs, baby. The TPAs. TPA, generally, you give them what's called alteplase. Okay, there's different types of thrombolytics, like particularly like TPA types, but alteplase is kind of the most common one that you'll give here. Now, generally, whenever you give someone alteplase, you can give them like sometimes like 50 to 100 milligrams. The big thing to remember with this one is that, again, how is it working? This one is busting up the clot, because what it does is it stimulates an enzyme called, so this is basically what's called a tissue plasminogen activator, right? It's going to stimulate plasminogen and convert it into plasmin. And plasmin did what again? It broke down the actual clot, the fibrin, into the fiber degradation products and the D-dimers. Okay? So this will bust the clot open, okay, in comparison to the anticoagulation. Okay? Now, they have a contraindication. I run into this a lot into the neuro science ICU. A patient maybe has a PE or they have like some other issue and they can't get TPA because they have a bleed in their brain. What do I do? An opportune kind of situation here is to do what's called an embolectomy, a catheter-driven suction or aspiration of that clot. So come down here for embolectomy. So for embolectomy, all you do is you take like a catheter, you thread it down through like the SVC, you thread it down through the right atrium into the right ventricle, you thread it through the pulmonary trunk. And this leads to that one quick thing that I was talking about with a saddle embolus. Saddle emboli are really dangerous because what they do is they literally they straddle right in this area here. They straddle between the actual pulmonary trunk as it bifurcates. And if you get a big clot there, you almost get no blood going into both of the actual pulmonary circulations. And so imagine the significant effect that you can have on the right ventricle and the significant hypoxemia that you develop. Either way, the catheter then runs up through the pulmonary trunk, and then what you do is it may actually help to suck up some of this actual clot. It may bust up some of the clot and then suck up the clot. So an embolectomy is good if there is a contraindication to TPA and they're hemodynamically unstable. Okay, beautiful. Now, another thing that you have to be thinking about is what if a patient, what are the other things that I can do to help them besides fixing the issue? Sometimes if a person is really hypotensive, what can I give them to augment their blood pressure? Well, supportive care measures. I can give them IV fluids. Effectively, if I give them IV fluids, you got to be very careful. Okay, you don't want to overload their right side of the heart. But if you give them IV fluids, it should hopefully increase their preload. It should increase their stroke volume, their cardiac output, their blood pressure. It should increase their effective arterial blood volume. If that doesn't work, the next option is to go with things called vasopressors. Okay, so these can augment particularly the hypotension that you see related with this condition. For the hypoxemia, you may have to progress with oxygen support, right? And this may come in the form of just a simple kind of non-rebreather. It may be nasal cannula, it may be Optiflow. You may even have to intubate the person. It kind of varies depending upon the scenario. But generally, there's some form of oxygen support. So we got fluids and pressors to augment the blood pressure, and we got oxygen support for the hypoxemia, and then busting up the clot is the definitive treatment. The last thing that I wanted to discuss here is what are ways that we can prevent these things from actually forming? How can we prevent clots from actually forming? Because this is a big deal, especially people with a lot of those risk factors that we talked about for Vercos. Sometimes these patients, especially when in the hospital, they may need to be on what's called subcutaneous low molecular weight heparin. Little doses like 5,000 units maybe twice a day. And it just helps to give them a little bit of the heparin to reduce the risk of forming clots. This is very important, especially in the hospital. Because if a person's laying in the bed all day and they're not moving around and ambulating, that's a problematic issue. You may have to give them heparin. The other thing is ambulating, getting around and walking. If you can get around and walk, you reduce that risk of stasis and you keep pushing the blood flow up. The other thing is, if they can't ambulate, they can't be on subcutaneous heparin because they have a contraindication with it. Putting on what's called some type of compression, okay, some type of compression device. And this may be compression stockings. This may be these little things called pneumatic compression devices. And what they do is they kind of inflate and then squeeze down, kind of basically replicating you trying to contract your calf muscles to be able to induce some contraction and push some of the blood flow up. So that's kind of another way that we can do this, is utilizing compression devices and pneumatic compression devices as well. So that covers everything that we need to know about PE. All right, Ninja Nerds, in this video we talk about pulmonary embolism. I hope it made sense. I hope that you guys enjoyed it. As always, Ninja Nerds, until next time.